أبنائي وبناتي الدارسين للجراحة العامة. This is Dr. Baki, Professor of General Surgery from Egypt. We are going to revise gallbladder through MCQ questions. And this is the first video in this series. وزي ما تعودنا أول فيديو أو اتنين بيبقوا straight forward questions وبعد كده الصعوبة بتزيد شوية. 51-year-old man has chronic calcular cholecystitis that is indicated for elective laparoscopic cholecystectomy. However, he is a chronic heavy smoker. Preoperative cessation of smoking should extend for at least. بيسألك هنوقف التدخين قبل العمليات الإلكتيف بقد إيه؟ 1 week, 2 week, 4 week, 8 weeks or 4 months. Go for 8 weeks. 8 weeks تعتبر أقل مدة ممكن فيها تقل البلمونري كومبليكيشن بوست اوبراتيف في العيانين المدخنين، ويستحسن طبعا ان هو يكمل اسبوع او 2 بعد العملية كمان. وخلال ال8 أسابيع دول ممكن جدا تديله اكسبكتورانت، ممكن جدا تمرنه على الانسنتيف سبايرومتري. اوكي، فدي المدة اللازمة. في طبعا عيانين يقول لك انا هبطل يوم او يومين او 3 او اسبوع، ده طبعا ما لا يحد من البوست اوبراتيف بالمونري كومبليكيشن. Go for D. 49-year-old female presents with jaundice. MRCP displays the presence of sclerosing cholangitis. She gives a long history of diarrhea for which she has received steroids on several occasions. She is likely to suffer from which of the following? Pernicious anemia, celiac disease, ulcerative colitis, liver cirrhosis, amoebic colitis. Of course, the colonic disease which is associated with sclerosing cholangitis is ulcerative colitis. Ulcerative colitis presenting in a long history of diarrhea for which the patient is receiving steroids. Go for C. A surgeon is removing the gallbladder of a 42-year-old man 3 weeks earlier. The patient had recovered from obstructive jaundice. قبل العملية ب3 أسابيع كان العيان اتعالج من obstructive jaundice. At operation, numerous small stones are present in the gallbladder. In addition to cholecystectomy, the surgeon should also perform one of the following. نظرا لأن العيان مر بأتاك of obstructive jaundice، فالمفروض الجراح وهو بيشيل المرارة يعمل intraoperative cholangiography, liver biopsy, no further treatment, choledochoduodenostomy, opening of the common bile duct to explore it for the presence of stones. Go for intraoperative cholangiography، هي اللي هتحدد لك إذا كانت ال common bile duct clear of stones ولا لأ، وبناء عليه ممكن تاخد قرار الاكسبلوريشن من عدمه. Go for intraoperative cholangiography. About biliary physiology, all the following statements are true except the gallbladder secretes bile salts, cholesterol is dissolved in bile by the effect of bile salts and phospholipids, the ingestion of fat stimulates gallbladder contraction, bilirubin in the bile duct is of the conjugated type, the yellow color of bile is caused by the presence of bilirubin. Exception or untrue statement is A. Gallbladder secretes bile salts. All bile contents are secreted by hepatocytes, by the liver, not the gallbladder. All other statements are true. This is number A, untrue statement. Okay? About imaging of the biliary system, one statement only is true. The majority of gallbladder stones show on plain X-ray. This is untrue. Only 10% of gallbladder stones are shown in plain X-ray. The majority of bile duct stones show on plain X-ray. This is untrue also. Oral cholecystography is the standard imaging study of detecting gallbladder stone. Nobody doing oral cholecystography nowadays. Ultrasound can see the majority of common bile duct stones. This is also wrong. because majority of bile duct stones are present in the lower third of the common bile duct, and because of obstructing air, the sensitivity of ultrasound to detect gallstones is not high. The visualization of air in the bile duct on plain X-ray may be caused by a bilioenteric fistula. That's right, go for E. Visualization of air in the bile ducts on plain X-ray may be caused by bilioenteric fistula. About ERCP, all of the following statements are true except ERCP is a useful study for visualization of the pancreatic duct in cases of chronic pancreatitis. Yes, that's true. ERCP is needed for the diagnosis of acute pancreatitis. No, this is not true. We diagnose acute pancreatitis by clinical picture, laboratory results, and CT. Only in very few cases of gallstone pancreatitis where there is stone impacted at the ampulla of water causing pancreatitis, we might need ERCP to treat the patient, to take the stone out, not to diagnose. Okay, so B is not true. The others will be true. ERCP is useful in delineating iatrogenic bile duct injury. That is true. ERCP is useful in the diagnosis of bile duct stones. That's true. ERCP can remove bile duct stones. That is true. The possible complication of ERCP include all of the following except ERCP can cause acute pancreatitis. Yes, that's true. Acute cholangitis. Yes, that's true. If we introduce infection in the presence of obstructed common bile duct, this may initiate acute pancreatitis. Perforation of the gallbladder. This is untrue. This is the exception. Go for C, because gallbladder is away from the pathway or anatomy of the ERCP. Okay? Perforation of the duodenum, yes, it might occur with ERCP. Bleeding, it might occur with ERCP. But gallbladder perforation is not logic at all. It will not occur with ERCP. Okay? The best imaging study for suspected gallbladder stones is plain X-ray, oral cholecystography, abdominal ultrasonography, magnetic resonance imaging of the abdomen, isotope scan. Go for abdominal ultrasound. Okay? Regarding biliary stones, a stone in the gallbladder causes acute pancreatitis. This is wrong. A stone in the common bile duct may cause acute pancreatitis. Okay? Regarding biliary stones, the commonest is the mixed type. Yes, that's true in our country, but in the United States, the commonest type is cholesterol stone. The majority are radio-opaque. The majority of biliary stones are not radio-opaque. Only 10% are radio-opaque. Gallbladder stones always cause abdominal pain. This is wrong also because most of the gallbladder stones are asymptomatic. So the only true statement here is B. Go for B, because the commonest in our country is mixed type stone. Okay? Other sentences are untrue. All the following factors increase the possibility of gallstone formation except hypertension, female hormones, hyperlipidemia, obesity, hemolytic blood disease. All can predispose to stone formation except hypertension. Okay? Of course, female hormones like estrogen causes stasis of the gallbladder and increases the susceptibility to precipitate gallstones. Same for hyperlipidemia, obesity, and hemolytic blood disease. Too much hemolysis will increase a lot of bilirubin, which is beyond the capacity of the liver to conjugate bilirubin. So unconjugated bilirubin will be too much. If it is joined with calcium, it will precipitate as pigment stone. So hypertension is not relevant to gallstone formation. Most of gallbladder stones are asymptomatic or cause biliary colic, choose the correct statement. Are asymptomatic, cause biliary colic, cause obstructive jaundice, cause acute cholecystitis, cause acute pancreatitis. The correct statement is A. Most of them, 70 to 80% of gallbladder stones are asymptomatic, discovered accidentally or not discovered at all. Okay? About common bile duct stone, not gallbladder stone. All the following statements are true except bile duct stones are more serious than gallbladder stone. Yes, that's true. Bile duct stones are present in 10 to 15% of patients with gallbladder stones. Yes, that's true. Calcular obstructive jaundice is usually intermittent. Yes, that's true. Bile duct stone that migrate to the intestine may cause gallstone ileus. This is untrue. Why? Bile duct stones that succeeds to go to the intestine should be very small, less than the opening of furter, which is just 3 millimeter. Such small stones which succeed in going from the common bile duct into the intestine cannot obstruct the intestine. But the stone which erodes from the gallbladder directly into the nearby duodenum is a big one, 2.5 or 3 centimeter. This kind of stone can obstruct the small gut. But the one in the common bile duct going to the intestine is small. So this is the exception. This one will be true. Common bile duct stones are commonly missed on ultrasound examination. That's true. About mixed gallstone, all of the following statements are true except they form the commonest type of gallbladder stone. Yes, that's true in our country. Usually a solitary mixed stone is present in the gallbladder. Mixed gallbladder stone is not solitary. They are usually multiple. So this is the exception. This is untrue. Go for B. The solitary is usually cholesterol solitaire, cholesterol stone. Okay? So go for B. Others will be true. They are usually faceted mixed stones. Yes, that's true. Their calcium content may make them opaque on plain X-ray. That's true. They contain cholesterol. That's true. 60 to 70% of the content of mixed stones are cholesterol. Okay? Precipitation of cholesterol to form gallstones is caused by all of the following except resection of the terminal ileum. Yes, that's true, because this will impair the enterohepatic circulation of bile salts. Left colectomy? No, this is irrelevant. This is the exception. This is untrue statement because left colectomy has nothing to do with precipitation of cholesterol to form gallstones. Crohn's disease, yes, because Crohn's disease impairs absorption in the intestine and consequently absorption of bile salts, and this will lead to cholesterol precipitation in the gallbladder. Repeated pregnancies predispose to higher incidence of cholesterol stones because of stasis of the gallbladder during pregnancy due to high content of estrogen in the blood. Contraceptive pills, yes, the same like repeated pregnancy. So everything here predisposed to cholesterol stone except left colectomy. All of the following features are characteristic of biliary colic except it is commonly induced by large or fatty meal. That's true. Pain is epigastric and right hypochondrial. That's true. Pain radiates to the back on the right side. That's true. Commonly accompanied with nausea and vomiting. That's true. Usually accompanied with fever and leukocytosis. This is untrue. Go for E, because if the pain is accompanied by fever and leukocytosis, think acute cholecystitis, not simple biliary pain, or as everybody knows, biliary colic. Biliary colic is a misnomer. As a matter of fact, the correct name is biliary pain. Okay? Go for E. The standard treatment of bile duct stricture after cholecystectomy is ERCP and stenting, percutaneous stance, hepatic drainage of bile, hepaticojejunostomy, choledochoduodenostomy, open drainage of bile by a T-tube. Of course, go for C, hepaticojejunostomy. Because stricture of the common bile duct after cholecystectomy is usually a high stricture, and you have to find a healthy patent part of the common hepatic duct in order to anastomose it to a defunctionalized loop of jejunum, what is called hepaticojejunostomy. Okay? The standard treatment of symptomatic gallbladder stone is low-fat diet or dissolution of stones with oral bile salts, or surgical removal of the gallbladder, or surgical removal of the stones leaving the gallbladder in place, or fragmenting the stones with extracorporeal shockwave lithotripsy like we do in renal stones. Of course, go for C, surgical removal of the gallbladder. If you attempt to defragment gallbladder stones, it will form more stones because no urine in the gallbladder to push the gravels outside the body, like what is happening in the urinary system. And that's why you cannot fragment gallbladder stones. And if you keep a diseased gallbladder in place and remove the stone, only this diseased gallbladder will make more and more stones. So go for surgical removal of the gallbladder. A stone in the common bile duct can cause any of the following complications, except it can cause obstructive jaundice. Yes, that's true. Bile duct cancer? No. Stone in the common bile duct is not known as a risk factor for development of bile duct cancer. Other items will be true. It can cause acute pancreatitis. Yes. It can cause acute cholangitis. Yes. It can cause cholangitic abscess of the liver. Yes. So, go exception is B. The specific risk of operating on a patient with obstructive jaundice include all the following except a patient with obstructive jaundice, if you operate, you might be confronted with bleeding. That's true. Septicemia, that's true. Liver failure, that's true. Renal failure, that's true. DVT, that is untrue. This is the exception. Obstructive jaundice does not increase the risk for development of deep venous thrombosis. Okay, go for E. Preoperative preparation of an obstructive jaundice patient include of the following except vitamin K tablets. This is the exception because vitamin K tablet in the presence of obstructive jaundice will not be absorbed because there is no bile salts reaching the intestine to help absorption of this vitamin K taken orally because it is a fat-soluble vitamins. There is obstructive jaundice, no bilirubin, no bile salts reaching the intestine to help absorption of vitamin K taken orally. In such cases, you have to give vitamin K better intravenously, preferably intravenously. Okay, so this is the exception. The other will be needed in a patient with obstructive jaundice prepared for surgery, like intravenous fresh frozen plasma to help coagulation of the blood, parenteral antibiotics to combat septicemia, oral and intravenous fluid administration to guard against hepatorenal failure, and high sugar intake to support the liver. All are okay except A. Regarding T-tube cholangiography, all of the following statements are true except T-tube is placed in the common bile duct after its exploration. That's true. A normal cholangiogram shows free flow of contents to the duodenum. That's true. A normal cholangiogram shows no filling defect in the CBD. That's true. The T-tube is removed 2 days after its placement at surgery. This is untrue. Go for D. This is the exception. If you decide to place a T-tube, you have to leave it for 10 days before deciding to remove it, because 2 days it will result in biliary fistula because its place in the common bile duct will not heal and there is no mature fibrous tract found to close the fistula tract. We keep it for 10 days to ensure fibrosis of its tract inside the abdomen, so that after removing it, there will be dribbling of few drops of bile, and after that everything will be dry. Before 10 days, there will be a biliary fistula. T-tube removal is a bedside procedure, that's true. So everything here is true except this D, because 2 days is very, very, very early. Okay? About bile duct cholangiocarcinoma, all of the following statements are true except choledochal cyst predisposed to cholangiocarcinoma, that's true. The possible extracolonic complications of ulcerative colitis include cholangiocarcinoma, that's true. Bile duct infestation with Ascaris parasite predisposed to cholangiocarcinoma, this is untrue. This is the exception. This is a wrong statement, because colonorhynchus sinensis or hepatic fluke is the predisposing factor for cholangiocarcinoma, not Ascaris. Okay? Hilar cholangiocarcinoma is known as Klatskin tumor, that's true. Percutaneous transhepatic cholangiography BTC is useful in showing the upper limit of the tumor, that is true. So the wrong statement here is C. About jaundice, all of the following statements are true except jaundice that is caused by hemolytic disease is characterized by no bilirubin in urine, that's true. In obstructive jaundice, bile salts retention causes itching, that's true. Cancer of the head of pancreas causes progressive jaundice, that's true. CT is the first choice imaging study for obstructive jaundice, that is untrue. When you are confronted with a case of obstructive jaundice, the first choice of an investigation is ultrasonography to rule out calcular obstructive jaundice, and sometimes ultrasonography can make you visualize a tumor at the head of the pancreas. Okay? In obstructive jaundice, defective intestinal absorption of vitamin K causes hypoprothrombinemia, that is true. So the wrong statement here is D. Iatrogenic bile duct injuries cause all of the following except it causes excess bile discharge through the drain, that's true. Hypovolemic shock, that is untrue. Common bile duct injury post-operative does not cause hypovolemic shock. Other statement will be true. It can cause biliary peritonitis, that's true. Biliary fistula, that's true. Obstructive jaundice, that is true. Okay, the exception here or the wrong statement is B. Thank you so much for watching this video. This is Dr. Baki, Professor of General Surgery from Egypt. Now kindly like, share and subscribe.